primary. My name is Frey Hewitt. I'm the acting executive director at the International Institute for Primary Healthcare in Ethiopia, and we're collaborating with Johns Hopkins School of Public Health Bloomberg on this webinar, and we've been collaborating for quite some time. We have done two of these sessions before on urban primary healthcare, and the first webinar was in June 24, where we talked about community health workers in urban primary healthcare with experts from Ethiopia, Bangladesh, and USA. The second one was on July 29th, and we were discussing about organization and management of urban primary healthcare, and experts from Ghana and Thailand presented their experience. And today we have a more exciting and insightful discussion from South Africa, Cuba, and India. So this is a platform where we expect where we expect different countries' experience will be shared, and it will be a good platform to establish collaboration and then help countries and program managers and policymakers to make to work on their current existing primary healthcare by taking experience from other countries, and then be able to attain universal health coverage. So we have Dr. Rajani Vaid from Johns Hopkins University, who's been working on and was doing an excellent job in coordinating this webinar and leading the process. So I'm gonna hand you over to Dr. Rajani, but I would like to say welcome everyone on board on behalf of the Institute. Dr. Rajani, over to you.
Thank you very much, Dr. Freywat. Welcome, everyone. And it's great to see such a turnout. And I notice also that some of you who've attended the last two webinars are here today as well. For those who are joining us today, here is a brief recap. Dr. Freywat already told you about the two webinars that we've had. I'd just like to highlight that the first webinar on community health workers clarified several issues related to adaptations made in community health worker programs to suit the needs of the urban poor. But they also raised many questions on the profile of urban community health workers, especially their role in primary health care related to public health action in urban areas and their positions in the primary healthcare team. In the second webinar on organization and management of service delivery, our speakers from both Ghana and Thailand highlighted that notwithstanding the success in improving population health outcomes in rural areas, policymakers needed to grapple with modalities to deliver primary health care to communities in urban areas. They also spoke of the challenge of incorporating lessons from robust rural primary health care programs to urban areas without substantially redesigning them. In both our webinars, our speakers addressed the importance of focusing on equity in designing and implementing urban PHC, given the heterogeneity of urban populations and the vast disparities in access to healthcare and other amenities in urban areas. Another common theme that emerged from both our webinars was the need for urban primary healthcare strategies to integrate multisectoral action to address social and environmental determinants for health. And that brings me to the topic of our webinar today. In this final webinar of our tripartite series, we focus on the interplay between multisectoral action and primary health care and the role of urban local governance in facilitating such convergence. As you all know, urban environments are more likely to see large disparities in socioeconomic status, with slum dwellers belonging to lower socioeconomic strata who face significant barriers in accessing care in the public or private sector, a lack of basic sanitation facilities and utilities such as water and electricity, and also a higher prevalence of psychological stressors that are the result of diversity of cities and increased population densities. Now, not all of these conditions can be addressed by departments of health working alone. The role of the private sector in urban areas, even when they do provide services for the urban poor, are limited to curative services. The health and social problems of urban areas in countries with different levels of infrastructure and health systems preparedness point to the need for policies, programs targeted to enabling multisectoral action. Now, while this is likely subject to significant variability, urban local governments have the potential to create conditions for healthy living, enabling citizen voice and participation, and facilitating multisectoral action to achieve greater health and equity. But urban local governments in many areas have failed in the delivery of primary health care, which we saw so tragically during COVID. This links partly to the historic imbalance between delivering secondary and tertiary care in urban areas and the focus on those services, and ensuring universal access to primary health care with its components of preventive and promotive health, public health, and action on multisectoral action. These are really complex issues, and there is an urgent need for a research and action agenda to further the development of resilient primary healthcare systems in urban areas. We do hope that these urban webinars will spur action in this regard. We are privileged to have with us today an eminent panel of speakers from Cuba, India, and South Africa, led by our distinguished moderator, Professor David Vlahoff. It is my pleasure to introduce Dr. Vlahoff, who's currently professor at the Yale School of Nursing and professor of epidemiology and microbial diseases at the Yale School of Public Health. Prior to this, he served as dean and professor at the University of California, San Francisco, and was also the senior vice president for research, the director of Center for Urban Epidemiological Studies at the New York Academy of Medicine. Dr. Vlahoff is the founding president of the International Society for Urban Health. He's been a visiting professor at the medical school in Belo Horizonte in Brazil to develop their programs in urban health, and served as an expert consultant to WHO's Urban Health Center in Kobe, Japan. Dr. Vlahoff is the editor-in-chief of the Journal of Urban Health. It is truly an honor to have him moderate our webinar today, focusing as it does on urban local governance and multisectoral action. Over to you, David, and thank you all for being here. I hope you enjoy this webinar and also walk ahead with us as we form communities of practice around urban primary healthcare. Thank you.
Thank you, Friwa. First of all, I just want to say how impressed I am with the series and the work of the International Institute of Primary Healthcare in Ethiopia, and the link with Johns Hopkins, where I graduated, by the way. So I want to get right into the program here because the speakers have a lot more to say than I do. And so let me really say we've got three excellent speakers, but let me give some ground rules for how we're going to be working here today. So the first is that I will introduce each of the speakers briefly. Each will give a 15-minute presentation, and we'll be helping them along, keeping that on schedule. There can be questions and comments. So if you look at the bottom, there's a question and answers box. And so please put your questions and comments in there. They will be monitored. Some of the speakers, will be able to answer some questions right away. Some may come to us at the end. And what do I mean by that? After each speaker finishes, there's 25 minutes, give or take a little bit, for questions and comments, so we can open up the conversation. So if that sounds good, let's move right to the first speaker. And I want to introduce Pedro Mas Bermeo, and he's a physician with dual specialties in epidemiology and public health. He's an emeritus research scientist at Tropical Medicine Institute Pedro Curi. He's an emeritus member of the Cuban Academy of Sciences and full professor of epidemiology and public health at the National School of Public Health, Medical University of Havana. He also has an appointment at Tulane University in the United States. He has served in the Ministry of Public Health as the National Director of Epidemiology, and his major academic appointments were General Director of the National Institute of Hygiene and Epidemiology in Cuba, the PhD Director at the University of Aden, Yemen, the PAHO as Sustainable Development Environmental Health Advisor in Jamaica, and he has served at least 20 times as advisor to PAHO and WHO. So I'm going to turn this over to Pedro right now, And we are really looking forward to your talk, please.
Good morning for everybody. Thank you very much, David. Finally, we did it. Well, I don't know if someone is helping me with the slides, or I have to do by myself. Okay, thank you very much. Thank you. Thank you very much. Well, again, thank you very much for the invitation. I am very glad to be here and to represent my country, Cuba. I will try to explain it's a challenge, by the way, to explain in very few minutes the ideas I want to share, but I will try to use the time that you are giving to us. Well, please, the next one. Okay, thank you very much. Well, here is just to introduce what we call in Cuba local governments. We have in Cuba 15 provinces and 168 municipalities, and each one considered as a local government. But for instance, each province has, let's say, 20, 10, 15, maybe 12 municipalities. As you can see in the maps there, in the 15 province, in the left hand, you can see the 15 province that we have and the municipality of Youth Island, Isla de la Juventud, that is considered as a municipality. Sorry. And on the left, we have the 168 municipalities in a country. Each municipality and each province has independence. And we will see what happened during my intervention in each, I will say, in the municipalities and in the province. Province, of course, is more important. They have a government body in both, and they are independent. I mean, the municipalities are independent, belongs to the province, but they have their own budget and so on, and their own health system. But the health system is a national one that I will explain later on. Okay, next, please. Well, this is the role of the urban local governments in Cuba, and this is more or less the main things that I will say, but there are more. But the main roles are, they have, as I told you before, municipal autonomy. They are working as a decentralization system. It's very important, the citizen participation, the satisfaction of local needs. And this is the last but not the least. It's the most important because it's the use the resource and capacity for action are elements that they are outlined, and that open a university of possibilities to achieve a decentralized municipality institute. This is a new thing that I will explain because since the year 2018, there are some change in this structure and the local governments in Cuba. Next, please. Well, talking about the healthcare, primary healthcare, and how they are working with the inside the municipality, and I will say that the municipality authority oversee community-based primary healthcare consisting in consultorios. Consultorios is the name in Spanish that we used to use in Cuba, and it's the first level of the level clinics for consultation with doctors and nurses, and belongs to a regional municipality. It means that one polyclinic has 20, 30, no more than 40 consultorios. And in the photo, you can see a consultorio is a place. We'll see the structure of the consultorio later on, but it's As you can see, this is in rollout vaccination against COVID-19. And this is one example that you can see in the slide. I mean, the photo of the slide. And this level, I mean, the consultorium, is characterized by general family doctor and nurse. They are working together. It's a model that we have in Cuba. Each consultorium has a family doctor and nurse, and which task is a lofty goal to improve the basic level of health of the interior nature. Next, please. Well, this is the photo that you are seeing now in the slide. Is a one example of the consultorium. As you see in the down, there are some people waiting for the doctor's attention or nurse's attention. It depends. And in the upstairs is the house when the doctor and some of them that have doctor and nurses living house. That means that they are living in the same community where they are working, and means that there is a very connection with the municipality levels in all the structure. Well, these doctors are responsible to keep in track of every patient in the area. They determine who is healthy, who is sick, and who is at risk, as well as make rounds to ensure that everyone receives vaccines, prenatal care, water, and sanitation. Means that they are worried about the environment when the people are living. And consultorium serves as decentralized frontline points of healthcare administration and strive to resolve around 80% of all cases. Next, please. Well, I want to say that we are, as I told before, since 2018, they are updating of the new process, updating the Cuban economic model, and major changes to improve the health sector, and have involved redefining functions and structure at all levels of care throughout the country. This is a new thing, and this initiative has shaped an organization that has proven to be capable of addressing disaster, epidemic, and extraordinary situation despite the severe economic blockade imposed by the US government since 1962 and amplified before and during the pandemic. Well, this is the next. I want to introduce the coronavirus, how we are working with the local governments. This is a situation that we have up to August 29, that means 3 days ago. You see, we have a complicated situation, more than 600,000 cases, and 5,140 deaths. It means that the fatality rate is around 0.7. It's slow despite the big number of cases that we have. This is the test that we have studied with the very, very big effort from the government, more than 7 million and 800,000 tests. We're talking PCR tests, and that is that we're using for the diagnosis. Well, next, please. Well, this is one example I want to show you because in the first part of the pandemic, we have no problem. This problem started when we opening the borders in November 20 of 2020. After that, we started the vaccination in 12th of May with our own vaccines. And after that, Delta variant appears, and you see how big is the situation, the peak that we have now. This day we are having around 6,000 cases by day, and around 60 persons died because COVID-19. And this is one example that we are facing in Cuba with the primary healthcare sector and, of course, the hospital and national institution. Next, please. Next. Well, let's see what is the role of the health sector in the, the municipality health sector inside of the pandemic of COVID-19. Well, the governmental institution organize and control for the national strategy of epidemic response, overseeing ministries and other state institutions. Means that we have a government, but the Minister of Public Health leads the national health system based on primary health care. This is one asset that we have in Cuba because the concept of the health system is primary health care. And it means that they are related with community level care and polyclinics. And secondary, of course, we have nursing homes, physical and mental disabled institutions, and in tertiary care, we have provincial hospital institute and scientific facility that enforces the health action fully supported by community. Next, please. Well, the main issues that we involved in the fight against the pandemic in Cuba, there are some community involvement, intersectoral collaboration, socioeconomic sector, of course, the Cuban public health national system characteristics is unique, it's national, free of charge, and of course, the political willing and the epidemiology approach. Because we are working according to this idea in the primary healthcare situation. Well, finally, I want to show the strategy, particular in Cuba, the epidemic response, including building of the universal character of the health system, and it's a strong primary health care. Means we are working at the local level and the municipality level, and this is one thing that we're working as you can see in the slide, carry on the nationwide door-to-door screening for persons with fever and respiratory symptoms, isolating confirmed case and placing their traced contact. And of course, we are from the beginning of the pandemic introduced the research and scientific institution in the strategy adopted. Well, now next, please. We'll say the pandemic challenge. Well, the main epidemiological and clinical characteristic of COVID-19 pandemic is a great challenge for all the health system and disrupting public service, economy, and generalized society. Therefore, in this condition, epidemic control is a challenge, especially with airborne disease implementation of unusual and extensive prevention and control measures, not always as effective as some considered, are difficult to put in action effectively. Next, please. Another challenge is because the natural wide circulation of SARS-CoV-2 highly contagious with the variants as Delta is the worst one at the moment. We will see what happens in the future. Decrease the effectiveness of public health and social measures, as well as available diagnostic vaccine and therapeutics. And little effective for movement restriction and other measures to reduce airborne transmission disease. And this is prolonged the time of epidemic and positive vaccine expectation and crowding of people in public health. This is more or less the challenge. And with this one, I want to finish and thank you all for your attention, and we'll see what happens after the final with answer and questions. Thank you very much for your attention.
Pedro, that was a really excellent presentation. I think that gave us a good overview. We've got a few seconds before moving to the next speaker. And so I'll just pick one or two. Can you say what proportion, what percentage of the Cuban population is vaccinated so far?
Pedro is on mute, David.
Pedro, are you on mute?
Sorry. Okay. No, sorry.
No, simple
I
question.
close to be sure that I spoke less than 15 minutes.
Yes.
But well, again, with the answering your question, we have 2 Cuban vaccine with the use of emergency approved by the regulatory authority in the country. And this is a good thing for you. But today, so far, we have 30% of the Cuban population fully vaccinated. No, sorry, but at least one vaccine.
Yeah.
At least one vaccine, and around 15% fully vaccination. And in Havana province, that we are almost finished the vaccination because it was a priority for the government, because the capital is very important in the vaccine campaigns. In the Havana province, we have so far 60% of the population fully vaccinated. With Abdala is one of our vaccines, and Soberana we are using as well.
Okay.
Thank you for the question.
Yes, there are a number of other questions that are coming in. You may want to look at them in the Q&A. You can answer those typing in, but we'll come back and discuss, because I think some of the questions really relate to all 3 presentations. So again, thank you. And we're going to we're going to move on to the second speaker. And this is Dr. Rajiv Dasgupta. And he graduated in medicine from the University of Calcutta, got his master's and PhD from Jawaharlal Nehru University in New Delhi. And he has a distinguished history in the epidemiology division of the Municipal Corporation of Delhi, and has dealt with a number of epidemics. So he's on faculty as professor and chair at the Center for Social Medicine and Community Health. And he, in his work, is coming up with a book, Urbanizing Cholera, Social Determinants and Reemergence. He's closely engaged with the Indian Council of Medical Research and a number of other organizations. He's been a consultant to UNICEF, the World Bank, Save the Children, and he is widely published in national and international journals, and also serves as journal editor. So we're really fortunate to have Rajiv with us, and I would like to turn over to you and hear your presentation. Please.
Thank you very much, Professor David Valov, and many thanks to the organizers. Happy to be back among the Hopkins community, and I see a few of my former colleagues and associates. A pleasure. I'll put up my presentation, and I shall surely stick to the time. I hope it's visible. So as the theme goes, we are talking today about the role of local governance in addressing multisectoral convergence for primary health care, and I'll offer a few glimpses from the Indian system. But a quick background first, why, and we all agree that this is an extremely relevant issue today. So in the context of the Sustainable Development Goals, the global health community argued that health is a prerequisite contributor and indicator for sustainable development, and that also recognized that most of the targets under the health SDG are unachievable by the health sector alone and are dependent on achievement of SDG targets under other goals. And to us, this is the centrality of this theme. And therefore, we need to refocus attention on how multisectoral action can be implemented to improve health outcomes, and how the health sector can cooperate with other sectors and not just SDG 3. However, as Professor Valoff mentioned, I shall go back to the cholera example and other related examples to demonstrate this, which of course comes from the pre-SDG era. But just to remind ourselves that the Alma-Ata Declaration also certainly pointed to the actors in addition to the health sector that we need to take into our fold. And therefore, going by the WHO 2011 definition of multisectoral collaboration, it defined it as the complex mechanisms, processes, relationships, and institutions through which citizens and groups articulate their interests, exercise their rights and obligations, and mediate their differences. And this I shall try to demonstrate through a disease control program. And I draw this from an earlier work of ours, of a very distinguished group of 15 authors in a workshop, as to what is multisectoral action for health. And we arrived, and this paper talks of a typology of four essential types. So in the type 1, we see health sector as a minimal actor in contexts where other individual sectors undertake their core business, but certainly have spillover effects for health. Second, where health sector is a supporting actor for cross-sectoral policies to address structural forces and social norms that affect all of society, including those that drive disparities. Third, where health sector is a bilateral or trilateral partner in contexts where collaboration is required between two or more sectors to produce joint or co-benefits and maximize health benefits. The One Health would typically can be considered as an example of this. And finally, where health sector is a lead actor in contexts where collaboration with other sectors is essential for the health sector to deliver its core mandate. And it is really the type 4 that I shall seek to demonstrate from my engagement with urban health in general and my own work experience of a decade with the Municipal Corporation of Delhi. So in the Indian context, the previous decade has been very significant for two national missions. The National Urban Renewal Mission, I shall not read the details. Essentially what the Urban Renewal Mission did was to focus on the social determinants of health, and the Urban Renewal Mission stayed away from health because there is a companion National Urban Health Mission, and it was understood that the determinants would be taken care of by the Urban Renewal Mission, whereas the core urban health services would be delivered through the national, or delivered through the National Urban Health Mission. There are critiques of this, but I won't go into that at present. And therefore, in the Indian context, the National Urban Health Mission has these building blocks or the components of convergence of urban planning to need assessment, of operationalizing health facilities, including setting up new ones, of smoothing in facility services, providing outreach, and building community linkages, some of which we saw in the Cuban example also. But as we realize that this is not at all possible for health sector alone, but really requires a convergence of very great magnitude. So what I shall demonstrate is an example of the multisectoral convergence in Delhi, which is a city-state of sorts. nearly 2% of the Indian population, or close to 1.5% of the national population. This model, I shall presently talk of that, actually started with the waterborne diseases. If you see this graph, this is of acute diarrheal diseases. There was a gastroenteritis and cholera epidemic in 1988. I'm going back in history in contrast to the COVID example in the previous presentation. So in 1988, there was a big epidemic in Delhi, which indeed serves as a landmark for some of the paradigmatic shift that we see in urban health services. Now, this graph really shows you that there has been a dramatic decline in deaths demonstrated through the case fatality rate, which has come down to nearly zero, and certainly a decline of cases of the incidence rate, which is marked by this pink line. This high here is on account of a new Vibrio cholerae strain, the 0139, which at that time, at the initial stages, was even considered to bring in the eighth pandemic of cholera. It didn't happen, but that's part of this rise. But I'm not really discussing the graph, but really the collaborative model that came up. Now, essentially, this was what is also significant is that till 1993, there was no elected local state government of Delhi. Delhi was administered only through the municipal system, but then there was in 1993 the new legislative assembly came up. The legislative assembly elections were held, and there was a new government, and therefore there was a new governance system that came with it. Again, it has had its ups and downs and its critiques. We won't go into that now, but there was this was a period of optimism, and therefore this multisectoral collaboration has to be seen and understood through that lens. But what's also important to understand, roughly in this 10-year period, there was a change in the government. So the second election came in 1998, but the collaborative model that was put in essentially continued, and the gains for water and vector-borne diseases certainly continued. So the model, therefore, that I'm going to show, Delhi is an extremely complex administrative system with the elected government, and then the municipal administration is also very strong, and there are both collaborations and conflicts. Again, both political and administrative. So under the leadership of the then health minister, who subsequently was the national health minister till, well, a couple of weeks ago, he was the national health minister through the COVID epidemic phase. He put in this collaborative system of actually getting in everybody around the table. So this meant the leadership of the national capital territory of Delhi, which is the government of Delhi, and the municipal corporation of Delhi, the technical leadership, as well as the administrative leadership, and the host of agencies whose functions have a bearing on water and vector-borne diseases. This includes public health, the Director of Health Services, which deals with the clinical and hospital care, the Delhi Water Services, the Conservancy and Sanitation Engineering, the National Institute of Communicable Diseases, which is a Government of India agency located in Delhi, the Delhi Development Authority, which is really a planning body, the Public Works Department, which deals with a host of infrastructure, and flood and irrigation, because it manages a range of water bodies. Now, what I'm really demonstrating through this is that it takes all of these to be able to sit around the table. And here we are talking of actually sitting around the minister's table every Saturday as a routine through the water and vector-borne disease months, which is nearly 7 to 8 months, particularly if you have a surge in dengue cases post-monsoon, dengue and chikungunya, and so on. So this is a drill that continues weekly, 8 months a year, and this is something which was set up by this leadership, but it also translated into a lot of horizontal dialogues across these governments within the municipal zones. There are 12 municipal zones, and there was a lot beyond what was happening in these 2 or 3 hours in Saturday. And many zones actually set up weekly zonal meetings on Tuesdays or Wednesdays, fixed day meetings, basically, so that as the system matured, much of the resolution of the problems started beginning to happening at zonal levels rather than coming up to the central or state levels. And the fact that the incidents declined, the case fatality declined, owes a lot to the system. And finally, what really are the lessons from this? First, that collaborative and distributed leadership is key. This was not a strongman leadership, which rarely works, though. And this is a strongman. We hardly talk of strong women on a lighter note. But this is so stereotype, the strongman leadership. But here, if you see the left-hand box, this is a distributed leadership, and this is not just a one-person-led leadership. What happened through these 5 years was that leadership capacity developed in zones across these sectoral partners, and each one began to have their own champions, and therefore the heads at the zonal level began to communicate. The heads of these agencies began to communicate, and therefore the health sector leadership actually need to prioritize competencies such as negotiation, flexibility, communication, and relationship building. This was all about relationship building, and that's what we owe this success to. And also setting some ground rules of engagement where non-governmental stakeholders, I'm not showing the non-governmental part because that's more at the zonal level, including civil society, academia, the private sector, and external funders, who all require clarity regarding their respective roles. That's very important. And these are more likely to succeed if they're institutionalized in existing structures and not championed by a single group or individual. And finally, it needs sustained efforts for ongoing challenges. And this is more likely if they're not driven by novel structures outside of mainstream systems, which often, when you actually have political will, a sort of a problem, I mean, sometimes the problem with that is of creating structures outside of the mainstream systems. The challenge of a committed political will is to be enabling the existing system to this collaborative mode, and that's what I seek, what I sought to demonstrate, but also that we remember these fundamental rules of engagement. Thank you very much. Professor Vallov, you're on mute.
Thank you. Let me repeat, that was absolutely a great presentation, and it covered so many points that we're going to come back to in the discussion at the end. And I think there's a nice balance of the two presentations that we've heard so far. But I want to keep us connected here with the presentations and the scheduling that's coming so far. I see people are putting in questions, and we're looking forward to getting to those. All right. The third speaker is Krish Balabji, and he qualified as a director, a doctor at the Royal College of Surgeons in Dublin, and a public health specialist at the Nelson Mandela School of Medicine, Natal University, KwaZulu-Natal. He has a diploma in occupational health, senior executive program, jointly by Harvard and Wits University, and an executive MBA at the University of Cape Town. He has served 40 years of cumulative experience in the public health sector in South Africa, including 11 years in clinical services in the public sector and 25 years as a senior manager in the health department of the Western Cape. So the senior executive responsibility included policy and planning, then promoted to chief director for regional hospitals. That included psychiatric, TB, emergency medical services, forensic pathology in the province. So he's currently appointed as Chief Director of Strategy, which includes responsibility for policy and planning, among other things. So it's a great honor for me to welcome Krish, and please let's get started.
Thank you very much, Prof. Walhof, and hi, colleagues. Really a pleasure to be here, and thank you very much for the opportunity. Is someone going to share my slides, please? Yeah. Okay, so I'm going to talk a bit about the South African context. Next slide. So I largely want to cover, just provide the context, give you a quick overview of the burden of disease that faces us, a few lessons from COVID, and then I want to focus on three areas: the opportunity for stewardship, violence as a public health problem, and talk a bit about community-orientated primary care, which we are experimenting with, and then some concluding remarks. Next slide. So in terms of the South African context, we have 9 provinces. In the bottom right-hand corner, you'll see those 9 provinces. The turquoise province is the Western Cape, and that's the province I'm located in. And we have 6 health districts, which is shown on the left-hand corner of this slide. Next slide. So we have a population of about 60 million. Urbanization is really varied across our provinces. Like a province like Gauteng or Western Cape has 95–99% urbanized, whereas a province like Northern Cape is only 20% urbanized, so very variable. At the moment, about 63% of our population is urbanized, projected to be 71% in a few years' time, and close to 80% by 2050. About 23% of our population are living in informal settlements, and unemployment is a major challenge in the country. Officially, it sits at about 32%, expanded definition 42%, youth employment close to 60–70%, and Black women 41%. And in the last year, 2020, we've lost about 2.2 million jobs. Now, if you see the graph at the bottom there, you can see unemployment has been a challenge way before COVID and has been on the increase over the years. We also have one of the most unequal countries in the world with a Gini coefficient of 63, and service delivery backlogs are mounting on many fronts, be it housing, water, sanitation, etc. If you take the burden of disease, this slide just shows from 2009 to 2016. On the top there, you will see the light blue, the increase in intentional injuries. So this is the interpersonal violence that we have, and you can see that burden has escalated, and so have the non-communicable diseases. And HIV has proportionately come down a bit. Under the female burden of disease, HIV has come down, but NCDs have gone up. So I just draw your attention to violence because I will be focusing on that specifically. Next slide. So this is just a bit more on that. You can see the increase in homicides from 2010 to 2018. And on the graph on your right, you can see homicides from firearms has really escalated over the last years with a slight increase in sharp objects. On the top there, I say quick wins have become quick losses in some ways, because just as government not coordinated, licensing of guns has not been strictly managed. Oftentimes you have a lapse in gun control, and these weapons then find themselves in the illegal sector. And then alcohol also the issuing of licenses, etc., has not been strictly managed. So these are factors that has driven some of this. Next slide. Just our pattern of deaths from 2002. From about 2008, 2009, we've seen a nice decrease in mortality, but the last year just shows you, and that's largely excess deaths from COVID, and our life expectancy has dropped by about 3 years. Next slide. So just very quickly, what are the lessons from COVID? Next slide. So I think, it would be fair to say that COVID has really precipitated a socio-economic and humanitarian crisis within the society. But the big thing is the health system strengthening efforts that we had before COVID has held us in very good stead during COVID. And that's an important lesson to build systems in normal times. As we prepare to come down the third wave, we're starting to look at how do we manage resurgence going forward? How do we recover? And how do we reset the transformation and health reform agenda? And I think we have to recalibrate our service provision for COVID, for comprehensive care, and the mass vaccination rollout, which might become an annual feature of our health service delivery. So it's an opportunity to redesign the service platform and to move beyond the bricks and mortar of our health facilities, optimize the use of technology to do business differently. And there are many other lessons of agility, responsiveness, data and evidence-led leadership and stewardship. And we could talk a whole day about lessons from COVID. But I want to then shift to the opportunity for stewardship. Next slide. So making the case for stewardship, why, what, and how? The World Health Organization defines the stewardship, and some key phrases here. It's about the careful and responsible management of the well-being of the population, the very essence of good government. And the next one, arguably the most important health system function, ranking above health service delivery, input, production, and financing. And I thought that was quite a telling remark. Stewardship is about developing leadership, coordinating mechanisms, a collective action towards a common vision, coherence, and collective intelligence. So there are many ingredients to the provision of stewardship. But the big point is that the provision of health services is necessary and mandatory, but not sufficient for optimal impact on health outcomes. We got to step beyond our provider role to a stewardship role. And the provider role is our comfort zone, but this is asking us to step up to a different role. And the case for intersectorial action has been made from Alma Ata decades ago and confirmed by the SDGs that we recently adopted. The socioeconomic situation is dire and creates a renewed urgency for intersectorial action. But this calls for a new mindset, a new way of being and doing our day-to-day business. It calls for a different skill set, a different quality of conversation, and a very different approach. And it's not so much about controlling all other sectors and all other actors, but it's about influencing more broadly. And the stewardship principles could be applied in intersectorial action. It could be applied in service delivery specifically. It could be applied in community engagement. Next slide. And I pose a question here. Can we move from universal health coverage to universal social service care? Right? So it's not just about the quality of healthcare, but the quality of life. Because if you take the needs of our vulnerable communities and families, these needs are interwoven and calls for a social safety net and integrated social service delivery. Right? So there's a need to explore and experiment with integrated social service delivery models beyond just health service delivery. And how do we address the conventional barriers and siloed culture in government and move beyond that and redesign our organizational arrangements, policies, lines of accountability and practice towards integrated delivery? So this is a question I pose to the audience. Then in terms of coordinated health service provision, there is a multiplicity of providers. We, in our context, the province itself is a major provider of health services. We also have local government that provides primary health care. We have NPOs, and we have a range of private providers. So that calls for a cohesive approach and bringing all of that together with some good stewardship. In the country itself, there's a debate for universal health coverage and national health insurance, and this creates a policy environment for better coordination and pooling of resources. But it's going to require much more than good contract management to achieve better cohesion. It requires a shared vision. It requires strategic goals. It requires building trustworthy relationships, effective governance mechanisms, and open communication, sharing of information, etc. So that's the case for stewardship. Then I want to just touch on violence as a public health problem and a model that we are trying out in the province. So this is quite generic. I mean, the steps would be surveillance, trying to understand the problem itself, identifying the risk and protective factors, and what are the underlying causes, then to develop some models and test it out and assess those interventions of what works and where does it work and how and what does not work, and then to scale up what works. So that's the generic approach. Next slide. So there's a quite well-known ecological model, and you can see violence is complex. It has a range of risk factors at an individual level, a relationship level, family level, community level, societal level. And I've just drawn a red block around alcohol, which is a key driver of violence. So this slide just shows that you're not going to have a magic bullet. It requires a complex, comprehensive approach to actually impact on violence. Next slide. So out of that, on the left here are a range of areas that need to be impacted upon, from creating safe spaces to empowering women, to ensuring victim support services, changing the harmful social norms on gender, relationships with children and caregivers, reducing access to firearms and knives, reducing the availability of alcohol. So it requires a whole range of interventions. But on the right, the question of how do we do this? And there are three areas. The one is data, the second one is evidence, and the third one is intersectoral collaboration. And I'll delve more into that in the next couple of slides. Next slide. So as far as alcohol goes, we have an unfortunate reputation of having a drinker consumption of the 6th highest in the world. Okay, and alcohol is the 7th leading risk factor for death and disability. Very strong links between alcohol and violence, and there's good evidence of what works and what not. Right. So we in the province at a higher level are looking at a alcohol harms reduction policy, and we are looking at amending the legislation around minimum unit pricing, reducing the trading hours, etc. That's at the more upstream level. At the bottom on the right there, I put a graph that just shows the correlation between alcohol availability and trauma in our emergency centers is almost like a light switch on and off. So on the left there, you would see there was an alcohol ban on the sale of alcohol, and you can see the drop in trauma admissions in our hospitals. And when on the 25th of July, the ban was lifted, you can just see how the graph starts to peak. And we've seen about a 44% increase in admissions to our ECs regarding trauma. Next slide. So these three areas are quite important. Now, using evidence is a good lesson we've had from COVID. And I think it's when applied to violence, what is the evidence of what works and what doesn't, and how do we localize and customize that? Then it's about integrated data. And we've adapted the Cardiff model, and I'll tell you a bit more about that, integrating data from various sources. So we have data from our emergency centers, from our forensic pathology services, from our police services, etc. And it's a question of pulling that data together and really knitting a cohesive pattern and seen and making meaning out of that. So that's an important thing about integrating the data surveillance. And then it's about local area interventions and how does one approach that? And I'll tell you a bit more about that. Next slide. So the Cardiff model, for those of you that might not be familiar, over a 51-month period in Cardiff, Wales, anonymized health data on interpersonal violence, particularly on the type of weapon used, at the time of the incident, and the location of the incident. This data was shared with police and local government with the aim of violence provision, right? And what was used as an outcome measure was hospital admissions due to violence, and the whole thing being by sharing that data, the interventions could be customized and adjusted and targeted in the particular areas. And the graph at the bottom just shows that in Cardiff, they managed to significantly drop the violence in Cardiff, and the top graph shows you comparative cities. So that's the Cardiff model that we are experimenting with in the Western Cape. Next slide. So this is a graph that just shows that firearms and sharp objects, knives mainly, are the two main weapons in interpersonal violence, but you can see the variation locally in the different suburbs. And therefore, it's very important to have local data and not generalized. In some areas, firearms are high as 92%, like in Elsie's River. And in other areas, knives are much more prevalent. So having local data is quite an important aspect of this project. Next slide. And so by providing the data, right, the police were then able to redeploy, right, law enforcement officers accordingly. So you see before 1st of July on the left-hand side, what it looked like during the week and weekends. And after we started to provide the data, they actually have committed to readjust the way they deploy police officers. And you can see how that has changed on the right-hand side. Next slide. And similarly, the actual number of police between different areas has also been adjusted. So you can see in some areas like Mitchell's Plain and Nyanga, it's actually been increased. And next slide. So just click again on this, please. Yeah, just click at the whole slide. But I think the big thing about the area-based team is that it's really about not about creating structures, but it's about how we can do things differently and how can we work more effectively. That's the big thing, because as government, we often have a habit of setting bureaucratic structures and trying to be in control, etc. This really calls for a very different way of working. And it calls for working on root causes, looking for opportunities locally, and solving community challenges locally. It calls about mobilizing the communities as active change agents, working across government departments and society, and also not having disconnected, separate strategies. It's about integrating a unified strategy that is cohesive, and also creating learning platforms and capability amongst communities. So we've identified 16 priority areas based on the data where violence is most prevalent. There's been liaison officers allocated to each of those areas who play a very important connecting role in trying to facilitate the conversations and bring people together. And it's also about mobilizing a wide range of local knowledge and resources. Next slide. Next slide. And this also calls for moving to a new safety paradigm. So we conventionally, as government, as managers, we kind of work within our boundaries. It's about us enabling now, and how do we become boundary spanners, and how do we work across boundaries? We are institutions, we worry about what happens between the bricks and mortar of our own facilities. But how do we now think about whole of society, whole of government, and collaborating across public, private, and civil society? And safety has conventionally been seen as the responsibility of the police and safety and security professionals. How do we make safety everyone's responsibility and embed it as such? So it calls for a new paradigm. Right? Next slide. you can just click this here. So there's three kind of phases. The first phase is really the information phase, and it's about gathering the data, looking at the evidence. The experiential knowledge locally is very important. Then it's about a process of developing a problem statement, looking at the stakeholders and mapping that out and make sure we are inclusive, looking at the assets that are in the community, and then what is the current interventions that are there, and then into an intervention phase of where will we target, what will we do, what are the quick wins, and how do we design those. So those are the kind of three phases we are using. Next slide. And so this slide here is then about now getting the data to see how do we monitor the situation. So almost 45% of the violence happens in 10 precincts within the city of Cape Town, right? And those are listed there. So these graphs are now just showing what the trend is. It's really very, very early days to claim any easy victories. So this is just an M&E tool, but in some areas we are seeing a downward curve, but I would be very hesitant to call that a victory. It's too early, but we want to monitor what that situation is. And hopefully, like Cardiff, we would be able to reduce the violence in the most affected areas. Next slide.
Very, very good.
Next slide. Okay, so then I want to touch on the third area, which is community-oriented primary care. And this is really about, as Abramson defined it, a continuous process, really to define what the community needs are, and then in an integrated way, primary care practice. So we are experimenting with this in the last year or two. Those are the principles. I'm not going to read all of that, but it's really about carving out well-defined areas and working locally on the ground in an integrated way. And oftentimes we have concentrated on what happens within the walls of our facilities. This is now looking beyond that and connecting what happens in the communities with what happens in our facilities, connecting our health workers with NPOs and the range of other stakeholders in the community. Next slide. So this is a defined area, and you can see we've got primary healthcare clinics, we've got community-based services, but we've also got social places like where NPOs operate, public events, sporting events, etc. We've got educational places, we've got workplaces. So this is about taking a geographic approach, a population approach, and how do we provide community-oriented primary healthcare comprehensively to the total population. And on the left-hand side, you can see there are a range of stakeholders there that we need to galvanize. And this is where the stewardship role becomes very, very important. And we as government must own that, and we must be able to play that stewardship role. Local government has an important function of municipal health services, and that includes waste and water, etc. And they are key players in this. Of course, primary healthcare can't be seen in isolation, and you can see the other levels of the system on the top of this view. On the top right-hand side, those three circles are quite important. So in our context, we've been talking about universal health care. We've been talking about community-oriented primary care, and we've been talking about the whole of society approach. And we're saying these three should not be seen as three separate initiatives. How do we govern, and how do we integrate, and how do we be cohesive in bringing all of this together? And there's a real opportunity to take that forward. Next slide. So these are the recommendations, and in the interest of time, I'm not going to read that, but it's about governance models, it's about packages of care, it's about service delivery models, etc., and a change management strategy. Next slide. So in conclusion, I think PHC governance in urban areas is very complex. The important principles of intersectorial social determinants, community engagement, these are decades old, and we need a fresh approach to re-energize implementation. COVID has provided an impetus to think and to be and to do differently. How do we apply this more widely? The relationships across sectors and spheres of government has been strengthened in COVID. How do we sustain that? And what has been presented here is emerging initiatives, very experimental, but it's provided a renewed impetus. The use of evidence and data in informing our system response has been a major lesson. Next slide. there's really a window of opportunity in the context of UHC, COPC, and WOSA, and health must step up and play its stewardship role in multiple settings and not lose this opportunity. It's an opportunity to redesign from a policy point of view, organizational arrangements, service platforms, models of care, and governance. So there's a lot of rethinking of how we reshape what we do. But there's a sense of urgency created by the humanitarian crisis on the one hand, and financial and budgetary constraints on the other, that we have to do business differently. And for our academic and researcher colleagues, I think in playing a role in distilling and translating evidence to inform policy and our health system response, embedding themselves in the local action at the operational level is quite important. And that's an important, significant contribution as partners in this. And of course, embedding learning culture and systems is also important. Thank you very much. And sorry if I went over. Thank you.
Very good. Very good. So, Krish, that was an excellent presentation. All three presentations were excellent. So we have 16, 17 minutes for questions and discussion. So I ask you to not go and chat, but to go into the question and answer section so that we can look at those. There's some questions that are dealing with some details of a particular program, what was the response rate and so forth. But I want to keep us on the broader questions, in terms of primary care, engaging that in urban systems, for example. And so I guess one of the questions I have is, and some people bring this up as well, is that there's national programs, right? There's national planning and priorities. And I know in some places, local sort of has to follow through on whatever the national priorities are. And in other places, it's decentralized to look at local circumstances. And so one could go either way. So based on your own experience, how much clout does the local primary care have? Is that a fair question? And I can take you one at a time. You could, any of you talk. Pedro, if you could unmute and ask me if the question was clear enough, or if you've got some thoughts on that. Again, it's looking at how much autonomy and decentralization is there for carrying out health issues and the linkage between the primary care, local government, other services, right? So we've talked about housing, education, so forth, and as that fits into the national, right? What models can we look at for urban primary care structure and organization? And I see you're writing notes. And so I can also ask Rahib if you have some thoughts on that. Krish?
I can go, David. So in terms of in South Africa, we have a constitution that clearly demarcates what national responsibilities are and provincial and local government responsibility. We have 3 spheres of government. So constitution provides the architecture for that, but health service delivery is in some ways a concurrent competence as well. But in large measure, national is meant to provide the policy direction and the norms and standards, and provinces really take the responsibility for implementation on the ground. And local government is really about municipal health services in a sense. So that's the kind of the legal answer to that. I think in practice, we have quite a bit of decision space to really shape what actually happens on the ground. Of course, sometimes you get things from national that you're not completely happy with, or, we want to be more integrated and cohesive, and sometimes it's very vertical, programmatic from national. So then that's where the dialogue and the engagement must actually happen to try and buffer some of that or reshape it, etc. So that's what happens in practice. Thanks.
Very good. Very good. Pedro, you're on mute. If you could unmute yourself. I'm going to ask you again, Pedro. There's on the bottom left of the screen is a mute, unmute. All right, let's get some help there. In the meantime, Rajiv, any thoughts on that?
I'll quickly respond to that. Yes, increasingly as health programs are not just national, but global, and therefore it's the global that often adds a different layer of urgency to national programs. That certainly has a bearing on what's really going to happen at the local level. But as I was trying to demonstrate through the two broad groups of diseases, which really dominate the epidemiology around the year, it all depends on the extent to which the political articulation is at the local level. Now, what happened to diarrheal diseases was the 1988 epidemic created its own dynamic and both a political and an administrative and technical urgency around it. Similarly, the dengue epidemic in 1994, which led to 10,000 cases and 400 plus deaths, but that's just official. It's more certainly. That led to a different, another layer of articulation around vector-borne diseases, and therefore these have acted locally, if I may, both through political as well as technical and administrative leaderships. Though, as you very rightly say, there is a jostling for space between global/national and local priorities.
All right, Pedro, welcome back. I want to.
You can hear me?
Yes.
Okay. Thank you. I'm very sorry for the technical issues, but well, in Cuba, we have a constitution as well. It's a national constitution. It's the law of laws. This constitution is writing everything and every detail about what is the relation with the central government, with the local governments, means provincial and municipal. But since 2018, we are introducing some change, not in the constitution, in the organization of the national level and the municipalities. And the idea is decentralize all the service to the local government, even the financial issues. That's meaning that this is a local government has, hotels and some private business. They receive benefits from this. The money that they pay by taxes and so on. But talking about public health, the role of the national level is to establish policies, goals, general strategies, and tactical things. And means that you have the national goal for the health in Cuba for the 2022, and this goes to the local governments, and they have to take all these strategies and the national goals, and they have to adapt it to the local governments. And these local governments now, the provincial one control how it's working the system in the municipality, but all the main decision according to the primary healthcare service specifically, they have taken at the municipality level. and they organize everything. But always taking into account that the country has goals that they have to follow. And this is very important. Thank you very much.
Very good. You know, so far we're talking about, you know, government, decentralized, you know, how does that work with, you know, primary care, for example? And, you know, one of my experiences here is, you know, health has to compete with other elements in government, and health isn't necessarily, you know, the top priority, you know, because there's so many economic development and so forth. And so WHO, Habitat, so forth, have talked about health in all policies. So can you get people looking at what are the health consequences of what's happening? And so there's new partnerships that happen that way. And so that's one element that we think about. I think the other is, what's the community engagement, right? There may be some important things, the violence in one case, addressing pandemics on the other. But, you know, the community, you know, are they just going to be told what to do and they must follow it? Or are there models of engagement to get people to buy in to what's going on? And so I want to bring that question up of, how do you get community engagement, particularly in urban settings and among the urban poor? But overall, I'd like to get some of your thoughts on that. So,
Well,
Rajiv, should I ask you first, or?
I am ready.
Okay.
But,
Okay, I'll go ahead. As you very rightly said, engaging with communities, and very specifically with the urban poor, is extremely challenging, to say the least. What lies at the core of urban poor, and specifically urban poor settlements, is this whole legal illegal question in urban contexts. And much of the social determinants issues, whether it's water, sanitation, sewerage, the foundations of good health are constrained, or their provisions are constrained by the legality or the legal status of the settlements. And therefore, that's where, or that constraint actually means that it's an impediment to goodwill and to meaningful community engagement. And those really are more urgent needs: water, toilets, sanitation, solid liquid waste disposal. Those really are far more urgent and needs on a continual basis. Those are 24/7 needs, whereas health service or public health actually isn't. And they certainly have a bearing on the health outcomes, but purely as a tangible service, if you see the community side of community view of it, those really are far more pressing. And that's where we lose, as a municipal agency, as a service providing agency, that's where we lose a lot of goodwill. And therefore, I think unless this legality issue is are resolved, and there's no easy resolution to that, unfortunately, that really costs us.
Yeah.
Thank you.
All right. Pedro, I see you're ready.
Yes. Okay, well, in Cuba, community engagement at the local health system and at the local and the urban places is very easy, because we have the family doctor, the primary health care, the doctors and nurses living in the same community that they have to work, and they know everybody in the community who has pregnant, who is has a social risk, who is the person who is different type of risks they know. And this worked very well because the community, they move the community very easy. We have now very good examples in the last 2 years, 1 year and a half with the COVID-19. For instance, we're now trying to vaccinate all the Cuban population in September with at least 1 dose of vaccine. Means that it's a big campaign. But we can do that because the community engaged. This is one example. They mobilize every resources. They offer houses. They offer local workplaces. They offer everything. Because if you don't have this type of engagement, it's impossible. On the other hand, it's the intersectoral approach, because you have to work with the community, but the community have problems with water, sanitation, garbage, everything. And because the doctor is one person who lives in the community, it's very easy to prepare an intersectoral approach. That very, very good things, even with water and sanitation, because remember that we have more than 11 million of population in the country as a whole, and we are a poor country. We are not a lot of resource, but the human resource works. This is a good news about the primary healthcare system. If this system works, it's a big challenge, big news, and good news for us.
Very good, very good. We've only got 2 minutes, and I'm supposed to give some sort of summary that's here. In terms of community engagement, I did some work in Belo Horizonte in Brazil. And one of the things that really impressed me was that there was a primary care model and periodic specialty consultations in particular areas, right? And how is it that you get the community engagement? For them, which I thought was clever, is that they had community outreach workers that came from the community. But there was nominations, then there would be campaigning, and then there would be a community vote for who should have the role. And so there was that sense of engagement overall. So different models in different places on how to think about local level community engagement, what kinds of empowerment, and also, as Pedro talks about, that relationship building. And also, I think what we're looking at is building the credibility, rapport credibility, so that the primary care become advocates that represent the community and have a voice, some social capital, some clout in terms of what's going on. The relationship of primary care to municipal is so important in that. If we're to extend that and to say, wait a minute, there are all these other services that are social determinants, then how is it that you bring people together, not just to say, oh, you do this and you do that, and we've got multiple problems, but how do you integrate that overall? Health in all policies has been one strategy, and there are pluses and minuses to how people accept that, but it's really looking for what are programs that can bring government together, integrate with primary care, and then also have that community sense that they've been listened to and that they have a voice at the table. So I think that's where we're supposed to end today. And I'm going to turn us back over to, tell me, Rajani, please.
Thank you very much, David. And I'd like to thank all of our audience in the webinar and our panelists, and to you too, David, for handling such an important topic and to give us your insights from the various countries. As I've said before, we hope that this webinar series doesn't end with this final webinar. We hope that we created a community of practice that will go on to explore these really difficult questions across different contexts. So thank you all very much. Bye-bye. Thanks.
Nice to see you. Thank you. Thank you.
Thank you very much.
Okay.
Bye.
Bye-bye.
You have done a very good job, David.
Thank you.
No,
Yes.
you. I'm so glad to meet you.